The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus, back for a question and answer session with Dr. Kirti Sivakoti. Welcome back.
Thank you. Thanks for having me back.
I've had several people stop me. I live in this insulated world where I don't talk to most of our listeners, but people were interested and people wanted to comment on what a great job you did.
Well, thank you. I'm so glad to hear.
So thanks for coming back. Before we start, do you have any disclosures?
I don't.
All right, should we dive right in?
Yes.
Okay. Our first couple of questions come from a very kind friend of the podcast, Miguel Knokel, who I should point out, I try to point out whenever I can, was the very first guest on this podcast way back in the day. So let's start. Question number 1, you discussed some medications. For a patient wanting to get off of a medication, which of these would I need to taper down more gradually, and which can I taper more quickly? Propranolol, I don't know how to pronounce this one, Kirti, Abradine?
Yeah, Ivabradine.
Ivabradine, Midodrine, and fludrocortisone.
Yeah, that's a great question. And in patients with POTS, thankfully, because of the low doses and the short half-lives, we don't have to worry too much about tapering medications off. Thankfully, the withdrawal symptoms aren't really that bad. But I think what we do worry about when we're trying to get patients off meds is, one, have they been compliant with some of the things, as in the physical therapy and the cardiac reconditioning things? Because the intention to use medication is a bridge for their physiology to take over, so they wouldn't need it for a long time. So a lot of the symptoms that we see when we stop medications are due to the underlying POTS physiology rather than withdrawal in itself. Yeah, we don't have to worry too much about tapering them down. So propranolol, for example, we do pretty low dose rather than high dose. And the thought here is we don't want to touch blood pressure too much. So we stick with 10 to 20 milligrams of propranolol. So should be fine to stop it, or if you want to taper like within a week or so, pretty fast taper. Ivabradine and Midodrine, we can stop that pretty fast. So Midodrine has a pretty short half-life and dose like 3 times a day. So there are some patients who also end up skipping a few Midodrine doses or take it PRN. So totally fine to stop it. And for Florinef, the doses are also pretty low, like 0.05 milligrams. That is also something that doesn't need a prolonged taper.
Excellent. Question number 2, for sick patients with POTS who are already on a medication, which of the same medication should I think about holding temporarily when a patient is acutely ill?
So the biggest thing here is related to their posture. So when patients are mostly in their bed when they're sick, we definitely want to hold Midodrine, because one of the things that we worry about with this is the supine hypertension and supine headaches. So if they're going to be in bed almost all day long, we want to hold Midodrine and then reintroduce it back when they're feeling better and they're more upright. But for the other meds, it should be okay to continue those medications during illnesses too, because with viral illnesses or with other illnesses too, I mean, we do worry about reduced intake, and their orthostatic symptoms are usually worse. So these medications can definitely help that response, help their POTS symptoms.
Would you mind just going back and expanding a little bit on the Midodrine issue with the postural headaches? Because that's an interesting factor about that medication.
Yeah, so with Midodrine, it's a vasoconstrictor, and it's the medication of choice in patients who tend to have like low blood pressures, low normal blood pressures. We tend to reach out to mitogen a lot for those who have more pre-syncopal, syncopal episodes. And it's the only FDA-approved medication for orthostatic hypotension right now. So of all the dysautonomias in POTS, mitogen is the one that's FDA approved. And most other medications in POTS are off-label use. So the downside to mitogen is because it's acting through vasoconstriction and increasing blood pressure a little bit, if we take gravity out of the equation, it could increase their blood pressure and cause some supine hypertension. So when we're also dosing it, we ask patients not to take it about 3 hours before their bedtime. So it washes off from their body, and then they should be fine to lay down without any supine hypertension or headaches.
And it's a fairly short-acting medication, right? You have to take it
Yes.
repeatedly through the day.
Yes, like 3 to 4 hours. So we usually dose it at like 7 to 8 a.m. and then 11 a.m. and then one dose around 2 or 3 p.m.
Do you find there's a limitation with your patients, or are they motivated enough, they just want to feel better, that they can take something repeatedly through the day?
Yeah, so when we prescribe it, we talk to them about we would like for you to take it 3 times a day, but a lot of our patients end up taking it during, let's say they have sports or it's a really hot day, they're going to be walking a lot. So we do have quite a few patients who end up skipping a few doses here and there. But the ones who we have found stick with all the doses are the ones who have noticed worsening of their symptoms of the medication, and they realize that it is actually helping their brain fog, it's helping their syncopal episodes, so they just continue taking it as prescribed, all the doses.
Excellent. Thanks. That was a little bit of a diversion. Sorry, Miguel. Question number 3. Which common medications should patients with POTS avoid?
Yeah. So that's a great question too. And a good way to think about that is which medications tend to lower blood pressure? Which medications are those which deplete volume or increase norepi? So like increase the sympathetic response in the body. So those are the ones that we watch closely. And I think the other thing here is different patients with POTS could respond to the same medication differently because it's not one disease, it's so heterogeneous. Medications that we think about avoiding with POTS, lowering blood pressure, so clonidine, guanfacine, we tend to stay away from those meds. But with that being said, there's a subset of POTS, hyperadrenergic POTS, where these medications could be helpful, but it makes us pretty nervous in reaching out to those meds unless we can put our finger on this patient and be like, we're very confident this is a hyperadrenergic physiology. Meds that deplete volume, we obviously talk about caffeine a lot and stay away from it. Diuretics, so some of our teenagers come on spironolactone, acne concerns, so we try to talk to them about that. Sedating meds, so if they're on trazodone, droxazine, Benadryl, those type of meds, we try to stay away from those. And then medications which increase heart rate, so stimulants, it's a little more nuanced. Because when we think of stimulants, yes, it can increase their heart rate slightly, but with that being said, treating ADHD can also help improve POTS symptoms because it helps them remember that they have to do all the things, the volume expansion things and physical therapy. So we don't generally stop ADHD meds, stimulants when we see patients. Will we talk to them about make sure your pediatrician is monitoring them closely. And also, stimulants have another target. There is some literature about that helping brain fog as well. So there are multiple targets to stimulants. I would say it's being thoughtful and intentional in which medications we are choosing and avoiding.
Sorry, Miguel, I'm diverting from your questions. Can we go back and talk a little bit more about caffeine? Because I think that we as physicians often vastly underestimate how much caffeine our patients are consuming. This isn't the 50 milligrams of a can of soda or 100 milligrams of a cup of coffee, but people are often getting hundreds of milligrams in one sitting. What do you tell your patients about caffeine?
So, what we talk about is there are so many issues with that increased caffeine intake. And there are patients who come in and they say, well, I'm having 80 ounces of fluids. And then we ask about how much of that is caffeinated and non caffeinated. Half of that is caffeinated. I'm like, that is a lot of caffeinated fluid that you're having. So, it acts as a diuretic, which means if they are drinking this amount of caffeine, they need to increase their intake significantly, their fluid intake to balance that out, which makes it harder on patients. So when we talk to them about it's important to limit caffeine. The other thing is sleep. Yeah, if their sleep's affected, that in turn is leading to this higher sympathetic activation in their body. Their nerves are not well rested and they feel like they're constantly exhausted, in addition to having the worst POTS symptoms. We definitely talk to our patients about staying away from caffeine. And if they want to have some caffeine, having a plan to put more fluid in their body so they are compensating for that.
It is interesting because I think a lot of adolescent patients in particular sort of reach for caffeine because of the foggy feelings.
Yeah.
And it probably requires a little bit more discussion.
Yes, absolutely. And then reframing that as when you're reaching out for caffeine, is it more so that your body needs a little bit more help with fluid? Drink half a liter to a liter of fluid with a salty snack with increased salt intake. So that way you're boosting your volume. So rather than reaching out for a caffeine. Yeah.
That's way too rational. Okay, next question comes from another great friend of the podcast, Lulu Waterhouse. And here's her question. This may need to be a full episode on its own, but I was wondering if you could expand upon mast cell activation syndrome and how it relates to or mimics POTS.
Yeah, so POTS and mast cell activation syndrome, I think this topic comes together often. A lot of patients bring these up. But from what we have seen, these two can coexist. Whether there is an underlying unifying physiology, we don't know that yet, but we know that there are a lot of commonalities between what patients with POTS and mast cell experience. So they both can experience similar symptoms like tachycardia, lightheaded, temperature sensitivity. So the symptoms are very similar, but I think we can definitely go a little bit deeper into the history, think about how it relates to the current consensus diagnostic criteria of mast cell. So we can make more intentional decision on should we pursue mast cell activation as a diagnosis in itself? Is it worth a referral to allergy immunology? Should we be testing the patients? There are some differences though. And we could tell POTS and mast cell activation syndrome patients apart based on that. So if there's somebody who's bringing up mast cell, I think it's important to think about, do they have recurrent systemic mast cell activation symptoms? So do they have more than two organ systems involved? So do they have flushing and GI symptoms? Do they have wheezing and GI symptoms? Or do they have do they have anaphylaxis, angioedema, whatnot? But a combination of symptoms. Do they have an objective evidence of a mast cell mediator during an event? And this, I think, is a lot more harder to measure. So, an objective marker could be tryptase. There are other mediators as well, but that I think is a lot more involved and it needs an allergy immunology referral to get that specific testing done because the samples need to be handled a lot more carefully. And the third aspect is, have patients shown any improvement with mast cell mediator therapy targeted at those mediators? So if our history is alluding towards some form of systemic mast cell symptom, which is not posture related, then we can start going down this path.
And how would you proceed with that?
Yeah, so in terms of having a diagnostic workflow algorithm based on history, if we are thinking mast cell activation, what I would do, and this is hard to, I think, accomplish, but what we would usually do is order a baseline tryptase level. So if patient's doing fine when they're in clinic, we'll just get a tryptase level and then talking to them about getting a tryptase level during an event. So when they're having symptoms that we think are a mast cell flare, asking them to come back to lab within 30 minutes to 4 hours and then repeating a tryptase level again. And if there is an elevation in tryptase level and there is a 20% plus 2 rule, which is if that acute tryptase is more than baseline tryptase multiplied by 1.2 plus 2, that is considered as increased tryptase level compared to baseline. We could start thinking about, we could diagnose them with mast cell activation, but if we need more clarity, let's say the tryptase level is negative. If you're thinking of other objective markers, as in some prostaglandin metabolites or urinary methylhistamines, whatnot, then I think would have to go the allergy immunology referral path. And in terms of therapy directed at mast cell mediators, when we think about the diagnostic criteria right now, so it needs all these three elements to it. So one is the multisystemic involvement, the objective evidence, and the therapy improvement with the therapy. And when we think of therapy, we could do targeted trials rather than throwing darts at patients and seeing if there is an evidence of objective improvement. So it could be, let's say, with Zyrtec Claritin for flushing type of symptoms with nasal ocular allergy symptoms. Is there any improvement? With H2 blockers, famotidine for GI type of symptoms, refluxy symptoms, do we see a change? With wheezing, respiratory symptoms, does montelukast, does that cause any benefit? So if there is any sort of benefit, along with an objective evidence of mast cell mediator and a positive history, I think we could make a diagnosis of mast cell activation syndrome.
So in all comers, patients who present with symptoms of POTS, how do you choose who to get a baseline tryptase on? Do you do that
Yeah.
fairly generally, or since there are so many symptoms that can be kind of confusing, how do you decide where to put that in your workup?
I think the first question that could help distinguish is, are symptoms associated with posture change? So if they are definitely posture change related, then I would have a lesser tendency to go down the mast cell path. But if symptoms tend to be, let's say they're lying down and they have a flare, or they're sitting and they have a flare, then I would have a higher tendency to be like, okay, maybe we need to start thinking about this. If rather than a baseline, so with POTS, it's this baseline fatigue and orthostatic intolerance related brain fog, nausea, dizziness. But with mast cell, if they're sitting and they have a flare, it's episodic, then I would have a tendency to go down that path as well. The other thing to think about is there an allergy symptomatology to it? So are they flushing? Is there wheezing? Is there angioedema, anaphylaxis type of symptoms? I think those point towards mast cell, I think, a lot more frequently. And I think those would be the big questions that would point us towards a mast cell workup.
Perfect. As you have reflected on what we've talked about over the past month, any other things you'd like to bring up?
I would say so with POTS and mast cell, not every patient with POTS need to be screened for mast cell. I think usually when patients come in and they talk about mast cell and POTS and hypermobility, there's this tendency to think of this big glob of all these diagnoses and how do we even go down this path? But I think a distinction could be, do patients have orthostatic symptoms at all? Even if it's not the frank dizziness and lightheadedness, is there brain fog related to posture change? Is nausea related to posture change? Which could, I think, take us to the point of doing or thinking about this phenotype a lot sooner rather than 3 to 4 visits later.
Perfect. And how about with POTS in general? Anything you'd like to talk about that we haven't talked about?
Well, I think the biggest thing is it's probably a lot more common than what we thought it was. And there are a lot more POTS mimics as well, lots of other diagnoses and disorders that look like POTS. So I think having a low suspicion, especially with the phenotype, the female predisposition, the teenagers, can help us get closer to the diagnosis and help these patients. And the other, I think, big thing is focusing on the functioning rather than the individual symptoms or heart rate change or textbook criteria.
Very helpful. Well, thank you so much for spending some time with us again this month. This has been so helpful and so enlightening. Hope we can talk to you again someday.
Yes, thanks for having me.
All right. And to our listeners, thanks so much for your questions. And we'll be back next week with more stuff. See you then. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.